Hey, welcome to the mini special lecture for the Ottawa ankle rules and the Buffalo rules. Here are some interesting facts that you may not be aware. Now, when people get seriously injured, they would often rush to the hospital to get checked, right? So about 10% of those ER visits are consisting of a midfoot and an ankle injury. And of course, they get there because it's very significant, and the physician will say, well, all right, because you're here, let's go ahead and get an x-ray, right? So the majority of them, the vast majority of them ended up getting an x-ray. However, only about maybe less than 15%, about 13% or so, of those x-rays will come back positive, indicating a significant fracture. So the other at least 85% of the x-rays are going to come back a negative. So the physician would say, all right, well, thank you for waiting around for about 4 hours at least. I would say at least. My typical ER visits were anything from like 7 to 8 or maybe 9 hours. So thank you for waiting. And then you know what, your x-ray was looking good, so it's probably just an ankle sprain. Thank you for coming. Oh, by the way, here's your big bill. Okay, so that's what pretty much our daily practice is, especially at the hospital emergency room setting. And is this really the best care that we can provide, or is there any maybe major room for improvement in terms of the time, in terms of the cost, in terms of the efficiency of our health, right? So the physicians and researchers at the hospital in Ottawa, they got together and say, okay, maybe we can come up with some kind of good, quick, effective screening method to see, hey, your ankles are looking pretty bad. Let's go ahead and get an x-ray. And you, it looks like you're doing all right, so we're not going to get an x-ray. It's probably just a soft tissue injury, so we're going to treat it as soft tissue injury. If we can come up with a great screening, kind of quick screening tool to say, you need an x-ray, you guys don't, that would be great, right? So that's really basic concept behind the Ottawa ankle rule, which was first introduced in 1992. Again, hospital up in Ottawa, they got together and they came up with this rule, clinical prediction rule. So let me walk you through this, okay? How you're supposed to apply Ottawa ankle rule to the patient that you're looking at, okay? Step by step, and because it's very important for every single one of you to know this and be very familiar with this and be able to apply this. First of all, step kind of 0 is exclusion criteria, meaning that you're going to go through these criteria. If any of these applies to your patient, you will not be able to use Ottawa ankle rule. You're going to have to use something else, something other than Ottawa ankle rule that you have in your toolbox. Maybe like regular tuning fork test, squeeze, bump, things like that. Okay? So here are some of the rules. Exclusion criteria. Number 1, if the patient is pregnant, you can't use Ottawa ankle rule. Number 2, if the patient has altered sensation in the area, affected area, so midfoot ankle, you cannot use Ottawa. Meaning that if they have like numbness issue or tingling, those weird sensory nervous issue in the area, you will not be able to use Ottawa. Number 3, if the patient happened to have just an isolated skin injury only, okay? Only the skin layer is being affected, cut or a scrape or whatever the case might be, and nothing internal is going on, you will not be able to use Ottawa ankle rule. Number 4, if the patient has already seen someone else, some other physician or other clinicians and therapists, you will not be able to use Ottawa. Number 5, if the patient sustained this injury more than 10 days ago, you will not be able to use Ottawa. The last one is if you see obvious deformity in the ankle, which would typically indicate major fracture, dislocation. It's an obvious one. You don't even have to think about going through Ottawa. Let's just go ahead and go probably straight to the x-ray room, okay? We used to have one age-related item, meaning that the patient is younger than 18 years old, you will not be able to use Ottawa. But the item got eliminated after several very strong researches got published saying that, you know what, we used Ottawa ankle rule to younger population and children, and it still worked just fine, okay? So after those reports, the last age-related item has been eliminated, so you don't have to worry about that anymore, okay? Again, if any of these applies, you can't use Ottawa, you're gonna stop it, okay, and then start to do something else. But let's say none of these applies to your patient that you're looking at, okay? Now we can move on to step number 1, which is the palpation. So now you're gonna use your fingers and then palpate these 4 specific areas, okay? So 2 of them are known as malleolar zone, and the other 2 is known as midfoot zone. So here's what here's where you're gonna palpate. So you're gonna take your finger and then palpate this posterior edge 6 centimeter basically distal part of the lateral malleolus and the medial malleolus, okay? So a little bit of fibula, a little bit of tibia, again up and down the entire posterior edge. You're going to palpate that to see if that's going to cause any significant tenderness. Okay, the other two are the base of the fifth metatarsal, and then the navicular, the entire navicular. You're going to move your finger and then palpate them. Why those four areas? Because those four are very commonly fractured area. Any tenderness there, significant tenderness, could indicate a potential fracture. Okay, so we're going to look for the tenderness. If you happen to find it, you're done with Ottawa ankle rule. You say the Ottawa ankle rule was positive for this patient because they happen to have a tenderness in those commonly fractured spot. So that's a positive Ottawa, meaning that, you know what, it's probably worth getting an x-ray. It would indicate the need for an x-ray. Okay, let's go ahead and get an x-ray is the conclusion. Then what if you don't find any tenderness? Well, if you don't find any tenderness here, you're going to move on to step number 2. Okay, which is the ability to walk immediately after injury. Now, depending on the scenario, this patient that you're looking at maybe just sustained an injury like 5 minutes ago, or it could be like yesterday, 2 days, 3 days ago. Whatever the case might be, step number 2, we're going to ask this question. All right, at the time of the injury, right after you sustained this injury, were you able to walk 4 steps unassisted on your own? Okay, and then when I say 4 steps unassisted, that's regardless of limping. If they are limping a little bit at the time of the injury, but they were still able to walk 4 steps, we're going to count that as yes, you were able to do it. Okay, if they were not putting any weight on that leg and just hopping around, we're not going to count that as 4 steps. All right, so regardless of the limp, if they are able to walk 4 steps unassisted, you know what? And that's what's going on, right? You don't have any tenderness in any of those 4 commonly fractured spots, and you were telling me that you were able to walk 4 steps unassisted right after injury. You know what? You're not doing so bad at all. So if that's the case, we say, you know what? Your Ottawa ankle rule was negative. You are good to go. I don't really see the need for an x-ray. It's probably just a soft tissue injury. We're going to treat a soft tissue. You are good to go. Okay? If patient here answers no, I was unable to walk 4 steps unassisted at the time of the injury, then we're going to move on to the final step number 3, which is, all right, so what about your ability to walk right now at the time of the evaluation, again, which is now. All right, so we're going to ask your patient to get up, try to put weight on it, and then try to walk 4 steps unassisted in front of me. All right, if they are at this time able to walk, this is what's going on, right? They don't have any tenderness in any of those 4 spots. They were unable to walk at the time of the injury, but now they can. Now they can. That means they got better. Okay? If it's a fracture, they're not going to get better that quick. So, just the fact that they got better so quick, probably not a bone issue. I don't see any need for getting an x-ray. So, the Ottawa ankle rule is negative. You are good to go. No need to get an x-ray. Okay? If they still cannot walk at this point, that's a consistent finding now. Okay, no tenderness. However, they were unable to walk at the time of the injury. They still cannot walk today as of right now. All right, consistently you're doing bad. So we're gonna say that your Ottawa ankle rule was positive, and we're going to get an x-ray because we see strong need. All right, so that's how you determine the need for an x-ray. If you are a very visual person, this diagram, this kind of flow chart, may be able to help you again visualize the entire flow. All right, so you got this patient here. You're gonna have to think about the exclusion criteria first. If any of these applies, that means you're gonna have to stop. You can't use Ottawa ankle rule, and you're gonna have to try something else. If none of these applies, you're gonna go down to palpation, step number 1, and then palpate those 4 areas. If you happen to find any tenderness, that's a positive Ottawa ankle rule, and an x-ray is indicated. Okay, if you don't find any tenderness, you're going to go down to step number 2. Were you able to walk at the time of the injury? Okay, if the answer is yes, all right, you got no tenderness, you're able to walk, you're good. We don't see any need for an x-ray, so that's Ottawa ankle rule negative. Okay, if they said no, I was unable to walk at the time of the injury, let's check it right now. We're going to check it now. If they show significant improvement, now they can walk, all right, we don't have to get an x-ray. Ottawa ankle rule negative. If they still cannot walk, that's 2 no, right? I was not able to and still cannot. two no's, that's very consistent, we're gonna say, all right, it's Ottawa ankle rule positive. Although you don't have any tenderness there, just because you're consistently showing us that you can't walk, we're gonna say that's Ottawa ankle rule positive, and we're going to get an x-ray. Okay, so again, if you are getting a little confused, you might need to spend some time looking at this chart, understanding the flow. So how effective is this really rule, right? So we happen to have a few systematic reviews and meta-analysis being published on Ottawa ankle rule, and then here are some of the combined statistics. Okay, so this is actually from the meta-analysis. So let's take a moment and look at those numbers. All right, I see sensitivity, specificity, and negative likelihood ratio. Unfortunately, positive likelihood ratio is not reported in this one, but you can kind of guess from the very low specificity that positive likelihood ratio is not going to be looking very good. Okay, so looking at this, I really think that these sensitivities are very high, anything from 98, 99 to 96.4 combined for ankle and midfoot. Okay, and also looking at the negative likelihood ratio, 0.08, 0.08, 0.17, those numbers are pretty good. So what does that tell you? Well, the Ottawa ankle rule has a very strong ability to rule out the need for an x-ray, meaning that when you apply Ottawa ankle rule to somebody and it comes back negative, you know what, that individual is probably good, we don't need to get an x-ray. Okay, you can probably trust that answer. However, look at the specificity. Okay, we see anything from 39.8 to down to 26.3. Those numbers are not good at all. Meaning that when you apply Ottawa ankle rule to somebody and it comes back positive, can you trust every single positive Ottawa and say, oh, you need to get an x-ray? Or are we still going to be wasting some money and time doing that? We probably are, right? So is there any way to improve this? We are very happy with its sensitivity and the negative likelihood ratio. Those are great. Let's keep that. But is there any way to tweak this one up a little bit to improve the specificity, right? That's going to be our next challenge. So the physicians and researchers up in Buffalo, New York, decided to come up with, all right, maybe we can add a little bit of tweak to this and then get it improved. Okay. The only change that they made is 2 of the 4 palpation areas. Okay, so for malleolar zones specifically, they said, you know what, instead of us palpating the entire posterior edge of the medial and lateral malleoli, okay, we're just gonna go for the midline 6 centimeter distal, okay, from the tip 6 centimeter up, just the midline. So that's the only change they made. Everything else is the same. Okay, so you're still going to palpate the base of the 5th metatarsal. You're still going to palpate the navicular. Okay, only thing that they changed was that thing. Instead of the entire posterior aspect, we're going to go for that midline only. Okay, again, everything else, like were you able to walk 4 steps at the time of the injury, can you walk it now, those flows are the same. Okay, only thing that they changed was this. And here's the new statistics. Okay, with that little change, it seems to significantly improve specificity. Remember Ottawa ankle rule, the original one. Okay, their specificity was anything from 26.3 to about 40%-ish. Okay, with this a little twist, modified version of Ottawa or Buffalo rule. Okay, sensitivity remained pretty high at 100%, but then specificity jumped up to 45 or even maybe 59%. Okay. So overall, what we are saying, looking at is the Buffalo rule seems to outperform the original Ottawa. Okay, so if you want to see the increased power to rule in the need for an x-ray, Buffalo rule might be something that you want to keep it in your mind. Okay, a little bit of tweak within the palpational areas. And also here's another twist. If you want to add something else like a tuning fork test, you might be able to do that. Here's a very interesting article titled the tuning fork test, a useful tool for improving specificity in Ottawa positive patients after ankle inversion injury. Okay, so here's what they did in that study. They got 49 participant subjects together. All of them received positive in Ottawa ankle rule, the regular original Ottawa. Okay, they all got positive, meaning that, you know, according to the Ottawa, x-rays indicated. Okay, and all of them sustained ankle inversion mechanism, some kind of injury. We don't know what that is. Okay, for that individual, this is what they did. They got the tuning fork, okay, got it vibrated, and then put it in 2 different areas. One was the distal very tip, okay, lata malleolus. And then the second area is kind of like a little bit below the mid shaft of the fibula, so we say that's a distal shaft, okay? And then put it in there. And they checked, okay, positive and negative. They said that any pain or discomfort complained upon tuning fork test would be considered as positive. And then here is their statistics. Okay, remember all these patients already got the positive Ottawa. They're just adding this extra step. Okay, so what do you think? When you put the tuning fork at the lata malleolus or the distal shaft, do you like anything that you see? I think specificity overall is a lot better than the regular original Ottawa 61, but look at this distal shaft version of it. The specificity went up to 95. That's a pretty high number. So the conclusion of this research was, you know what, it significantly improved the specificity, especially when you put that vibrating tuning fork over the distal shaft. So you may not want to jump into every single positive Ottawa or ankle case and say we need to get an x-ray. Let's try to do something a little extra, add one more tool, okay, screening, to really see, all right, do we really need to get an x-ray? Because if I happen to put this over the distal shaft and then you say that it was painful, there's a really good chance that you really need an x-ray. Okay, and then if you don't have any pain or discomfort, then I can probably say you're good to go. So adding something like that, okay, may also be able to make some significant impact into your clinical evaluation. So something to keep, okay, in your mind. So what's the advantage of Ottawa ankle roll and buffalo? What are some of the, I guess, what's the point, right? So the main thing was it's going to cause overall cost reduction on the medical bills, because we're going to be able to eliminate those unnecessary x-rays. And also it's going to produce some consistency in care and also the quality of the care. If all the hospitals in this nation and all the therapists, athletic trainers, physical therapists that are working very closely with an acute kind of an injury setting, okay, are going to use this Ottawa ankle rule or buffalo rule consistently, okay, that's going to create the national standard. Everybody's going to be doing the same thing. Everybody's going to be making a judgment based on the same test, same finding, okay? So that would create consistency, and the quality of the care, again, across the nation is going to go up. And also it's very time saving as well. Ottawa ankle roll, buffalo rule, it shouldn't have to take more than, 3 minutes to apply this test. So it's pretty efficient, and then you can potentially, again, decrease the amount of the time that people have to spend to wait around trying to get an x-ray. Okay, so overall it's going to be very efficient. Ottawa ankle roll is reported to result in anywhere from 19 to 38% of reduction in the x-ray costs, because we can cut some of the unnecessary x-rays. And buffalo rule, the number might be even higher, 54%. And if we are to do this nationally, all right, it's estimated that the national cost saving is going to be anything from $18 to $90 million annually. That's every year. So overall, Ottawa ankle roll and buffalo rules is a very valuable tool for all the clinicians, okay, to use, to know and to use. So again, regardless of your special area, athletic training, physical therapist, occupational therapist, this special task clinical prediction rule is really something that you should be very familiar, you should get yourself very familiar with and be able to use it on a daily basis. Okay, and here are some of the references that I use. If you have any questions, let me know.